interact with the center of the health system, which is the patient.
Okay, let's talk about the health sector of Uganda to start with. How do you look at it? How would your judgment be on our health sector? Because it's one thing that concerns all of us, and it's one conversation that we can't desist from. We talk about it. The other day we flew the speaker to Seattle in Washington, and the conversation was everywhere. Why did we have to do that to the speaker? Why don't we build our own systems here? And quite a number of things that we say. Let's talk about our health systems. How are they, according to you now, who are the stakeholders directly in it?
Yeah, the Uganda health system has been really tested over the last 24 months. I think COVID-19 has shown us all our cobwebs where they are. It's shown us our strengths where they are. The one thing I can say is that it is a very responsive health system. When we needed the system to work, it worked. It worked the best it could with the resources that it had at hand. We all know that we have a challenge with out-of-pocket expenditure, where 41% of the health expenditure in the country comes out of our pockets, you, mine, our relatives and our friends, which is not ideal. Then 41% again comes from health development partners. So we have external entities that are investing in making sure that you and I can access health. And then government of Uganda, based on the tax collections, then comes and chips in the rest. So as far as the health system is concerned, the resources available are very thin. We know we have a very thin tax base. But even the proportion of our national budget that goes to health is only about 7%. Ideally, it should be about 15% or even 20% to really make sure that we fill all the gaps.
That's a budget declaration or something?
Yes, the Abuja declaration. And the WHO recommendation is that the country is supposed to spend $85 per year per person, but we only spend about 58. So you can see there's some shortcomings when it comes to our ability to know that when you walk into a public facility, you will find the human resources, you will find the drugs, you will find the lab person at the lab with the right reagents to be able to carry out your diagnostic tests. And really that is where the private sector comes in, because we have the dexterity to be able to find opportunities where we can invest, to be able to complement where government is providing services, and we can see a need to be able to meet that gap. Yeah.
Okay. It's said health is very expensive in this country. What can we do about that? Because I think, yes, it is.
Health is expensive, but I think we also have to remember we're a landlocked country. So there are things that are really beyond government. I think as a citizen of Uganda, I can demand services, but I also have to be cognizant of the fact that we import quite a lot of what we use in our health system, and so we are at the mercy of forex pressure. We're at the mercy of imported consumables and drugs that are priced beyond what we could really afford for our health system to be able to be sustainable. So that's one of the challenges. And then remember, we also pay the least to our health workers. So we can't say that the system is expensive because the doctors are expensive or the nurses are expensive. Because I'll give you an illustration. An intern in Kenya is paid the same as a specialist in Uganda.
An intern in Kenya?
Yes, an intern. So the disparity in salaries means that we do have a bit of a brain drain challenge. However, what we've tried to do as a country is see how we can come up with a public-private mix, whereby we have a mixed health system where we have government providing services, but where they are not and where they cannot be, the private sector steps in. It's not ideal, it is not where it should be, but I think we're on the journey there. We're really hoping that a lot of the policies and the legislations that are coming into place now will compel us as a country to take that leap forward. But it really comes from political will. And that political will comes when we talk to Parliament and we say we must have at least 15% of our national budget going to health. Then we will see what you and I want to see in this country when it comes to health.
Is a 15% achievable?
It is. We just need to reallocate. It's like in your home. You can say that we spend 20% of our income in this house on food, or we can say we're going to spend 60% on food. It's really about the will of the people, that the decision makers within that household to decide. And I feel that the decision makers in this country as Parliament, it is really up to them to make sure that they put the pieces in place to make sure that we are able to provide our country with the health care that it deserves.
Okay, very important. Now, very many years ago, about 20 years ago, the Minister of Health started on a conversation of a national health insurance system or scheme. And the conversation has started. It's as old as 20 years. And I think sometime last year, Parliament passed a bill, which I think is now before the President, waiting to be assented to become a law. How do we think that the national health insurance scheme can actually be a game changer in our health systems?
I think the National Health Insurance Scheme will really put health in the hands of the people. What we're finding a lot at the moment is somebody goes to Mulago and yes, the health is free, but they don't understand that it's actually not free because we're paying for it through our taxes. And so we can abuse the system, we can pilfer, we can waste, because we don't really see the chain of where the money is coming from. So if we're introducing a system such as the National Health Insurance Scheme, everybody has some skin in the game. We're all putting in whatever it is we have, whether it's 1,000 shillings, 10,000 shillings, or someone like you can put 1 million shillings. But it's really
more
based...
than 1 million.
Even more per month. But I think at the end of the day, that contribution allows us to, A, be entitled to demand a level of service that we are entitled to because we put some money there. But then we also care about the health system. We make sure that we don't pilfer. We make sure we do not waste. And again, I'll link it back to our household, that if you're buying things for your home, you're a bit more careful about how things are used and how the money is spent and the resources that you have to make sure they go as far as possible. And that's what we're really looking at with the National Health Insurance.
How will Ugandans understand this? Because, you know, when you talk about something where Ugandans are supposed to put in money, it gets back to we pay taxes. Just recently, we had a conversation over paying for the toll road on Entebbe Expressway. And then Ugandans are saying, okay, now you dividing the country between the haves and the have-nots. If you don't have money, then you don't have to drive on this particular road. How would people understand the national insurance health scheme itself? How should the people understand for what you're actually saying that we will do this? What is that supposed to be? Is government going to put their money for Grace and Semakola and any other person, or what?
That's a really good question. I think it's one of the issues that has held the National Health Insurance Scheme from moving forward, because people don't really understand what does it really mean for me as an individual.
Exactly.
The gentleman selling Rolexes to the gentleman driving a luxury vehicle, what does it mean for them? And I think at the end of the day, what it means that we all have family members that rely on us for healthcare. Whether it is they have malaria, it's a house help, whether it's a relative in the village.
Whatever it is.
They rely on us. And at the end of the day, what we're saying is to help cushion us from having to have those unexpected costs. Put some money aside. Across this country, we have various people saving in groups. We have burial groups, we have wedding groups. We have all kinds of groups in all our communities. Exactly, Muno Mukabi. And from the parish level to a national level, these SACCOs and groups are there. And what we're saying is that since you're already putting some money aside, now put some aside for your health, because it's the most valuable asset you have as an individual, is your health. So why don't you, while you're busy buying your car or building a very nice house, put a little bit aside for your health. Because at the end of the day, when you fall sick, you don't want to panic. You don't want to go around asking, because we all hate borrowing money. We all feel uncomfortable asking for somebody to give me money to pay for this. So you'd rather say, let's put a little bit aside so that when you need it, you can access it. And of course, we have some gaps in understanding when it comes to insurance. So I worked for 10 years in insurance, and one of the questions that always came up, but if I don't fall sick, but I've paid, what happens? Do I get my money back? And of course, there's different levels of understanding when it comes, because, for example, if you have an askari that guards your house, you don't get robbed for an entire year. Do you tell him, give me back the salary, because I've been paying you and I never got robbed? It doesn't work that way. The way it works is on a pooling mechanism, whereby we all put a little bit into the pool. Now, if God forbid I fall sick, I can claim from the pool. But if you haven't fallen sick, you're lucky, because this year it's not been you. But next year it could be you. It could be your friend, it could be your neighbor, it could be your relative. So we're all just looking at it as a social enterprise, whereby we're all contributing to a single pool, and we all see how we can benefit. But we also have to remember, national health insurance does not preclude other mechanisms, whereby those who have a higher expectation can still benefit. So you have your everyday person, a boda rider, the person selling Rolex, the teller in a bank, the everyday people. They can access medical care either through their employer right now, for those who can afford private health insurance, but right now the others are at the mercy of their pocket on that particular day at that particular time. So we want to give them some social protection. But then we're also saying, what happens beyond that? What do we do for ourselves to protect ourselves? We have to look at promoting good health behaviors. And that's why it's really a multi-sectoral approach for us as a country. How do we protect ourselves in terms of how we eat, how we exercise, so that we minimize how we claim on that fund? Because it's not a bottomless pit of money. And one of the things we've been saying, because we're all contributing, and we're right now in the formal sector, people, if you count the people that contribute to national health insurance, to NSSF, you'd say there are less than 1 million people that are putting into NSSF. The rest of the people are in Chikubo, who no one really knows how to get the money out of them to contribute into the scheme. And so those are the questions coming out for the national health insurance. How do we get everybody to put in? Because the bigger the pool, the more the benefits, the more sustainable, the more likely if you need an intervention that is expensive, like you said, the speaker had to fly to Washington. We're able to build a health system in Uganda so that we keep the money within the country to build our health system, rather than sending the money to another country to treat our citizens in Uganda. We really need to see how to, this is just another way for us to finance our own health system. I think people think that government will stop spending on health when the national health insurance comes in because I am now contributing. That is not how it's going to work. Government will still be funding the health system, but we'll be asking people to then put in ring-fest funding that will go to build this national health insurance scheme. And we also have to remember that development partners that are contributing 40% are scaling back their contribution. So as a country, we need to take pride in ourselves and be able to stand up and fund our own health system. And the one way to do that we're looking at is the National Health Insurance Scheme. It's not, if we look at Tanzania, they've had it for over 20 years. And it is so robust. It has such wide benefits that it's even putting other private health insurers to the test. They're competing because they can't. They're finding that the benefits under the national health insurance are so good that people would rather be on the national health insurance. So they have to compete on that level. When you look at Kenya, they started a good 10 years ago now, but because it sat under the president's office, it had that political push. It is what they call their journey to universal health coverage. It is their ticket to make sure that every Kenyan has access to health. So they put it with the president, so it has that weight. And now Kenya is adapting their model to make it more efficient. They contribute 3% of their salaries. The employer doesn't contribute. The employee contributes because they're the beneficiary. It covers up to 6 people. And they have different schemes within that cater for people, for pregnancy, for orphans and vulnerable children. If I was to ask you now, where do orphans and vulnerable children get care? You'd say, they're at the mercy of whoever can contribute on that day. But if we have a national health insurance, the most vulnerable in our society have that cushion and that social protection.
Very good. Now, you are speaking from a very professional angle, and of course, I'm thinking to very professional people and civil people who are understanding you. But you know that in this country, the biggest employer is politics. The political arena is the biggest employer in this country. We have about 2.3 million political leaders, from president to local councils in our villages. And until they come out to say something, all their trust, all the trust of the citizens is with these politicians, the councillors who possibly do not know anything about that. And we get it to now, that's why it is. We are talking about contributing to this particular scheme. And the other question will be, just talked about NSSF. We can discuss NSSF until you ask people, but how many of you are saving with NSSF? And that's when you see people running away. Dr. say we'll run away from this conversation of the midterm payments at 20%, etc. Because you now know that all of them do not save with the fund. And now when you talk about this particular, somebody will ask you a question, okay, so what does that mean? Because we have a country where we know that, or think that everything that we pull together will be eaten by somebody, or some 1, 2, 3, 4 few people who steal from us. And we have that phobia, we have that worry, that we'll pull the resources together, then we'll hear that Grace has actually run with that money. She's gone with that money. Something like that. So how are we going to convince the people that this is a scheme that is going to benefit all of you, in that, or having it at the back of our minds that we even do not understand and appreciate insurance? It's very common in this country. You go buy a car worth 100 million shillings and you only just have a third-party insurance of 75,000 shillings on it, and nobody goes for a comprehensive. Because when you go for comprehensive insurance, and they'll tell you, but I'm supposed to take care of my car. What about if my car does not crash or have a problem, a bigger problem, in this whole year? So this insurance company takes my millions of shillings. No, I will only pay the road user fee. What needs to be done to make sure that people understand these things?
I think they really need to take it down to the grassroots. I think the way we're doing the parish development model is where we need to take insurance, because it is the only solution to avail healthcare to everybody in this country. There's no shortcut, there's no way around it. It's happening all over the world. We're actually the last in this region to do it. So we need to do whatever it takes. And like you said, we have a lot of political leaders. And like I said, it needs political will. In Kenya, it sits in the president's office.
To give it that weight.
To give it the weight, to give it the push. In Rwanda, similarly, it is driven by literally the president's office. It is heavily subsidized by government. It has that push. In Tanzania, it had the push. So similarly in Uganda, it must have that push from the local councillor, like you've mentioned, right up to the president, because at the end of the day, these are the people that people go to in the community to ask for contributions for their health care. We have a number of politicians who we interact with who say, oh, my constituents needed money for their health care. If we had a national health insurance, half of those problems would really go away. But you're absolutely right. I think one of our biggest challenges is understanding how insurance works. And that comprehensive car insurance, the incentives that are built into insurance, if you look at no claims bonuses, for example. In fact, I advise everybody who has comprehensive car insurance, when you're renewing, if you've not claimed, ask your insurer for a no claims discount so that you are incentivized to keep renewing that comprehensive car insurance. At the end of the day, insurance is thriving all over the world because it makes sense. It takes away the catastrophic expenditure that can push you into poverty. We remember in COVID, people were talking about selling their land titles, selling their cars. We need to avoid that in our future if we're to grow as a country. And remember, we're striving for middle income status. The minute we get to middle income, donor funding reduces. So we really need to make sure we prepare ourselves as a country for that time. Okay,
very important. Now, we talk about a scheme which I think is very important, very good, and I don't know whether you've interacted with the bill itself, I don't know. But the issue here could be, how come the people until now, we talk about something that started in 2002 almost,
yes.
20 years later, and people don't seem to know much about it. Why do you think there's not been a lot of effort to let the people know what this is, to appreciate and possibly join hands with you to actually say, we are demanding for this and we should have this by yesterday?
Yes, I think we've been challenged by the last parliament. We'd spent a lot of time with them, educating them, the health committee, so they understood.
The last parliament, 10th parliament.
The 10th parliament. Now we have 11th parliament. We're going through the process of sensitizing them so that they can come on board to appreciate and understand. We've had some very good interactions with the health committee. We're having ongoing engagements. Right now, the Ministry of Health is engaging different subsectors and stakeholders to make sure that they fully understand. But we need to have an investment in communication around NHIS. It is not sufficient to say we're going to rely on the Ministry of Health to engage stakeholders. There are 44 million people in this country, from the children in primary school to the students in secondary and the tertiary education. They all need to understand insurance. It can't just be their parents, it can't just be politicians. We need to integrate it into our education system so that people understand, and that's why I was mentioning that it's a multi-sectoral approach. It needs both the politicians, it needs both society, it needs every subsector and every sector to fully understand. Government doesn't insure. If you go to government and you say, which of your assets is insured? None of them. And so if they burn down, they fall down, cars crash, they buy new, and you and I have to pay. Yet they could claim from insurance. So it really needs a multi-sectoral buy-in to understand insurance. It needs a political push, but it also needs us to interact with it from the topmost level in this country, for them to also see the other side and the benefits that it could benefit. Because we appreciate the last time we interacted with His Excellency, his biggest concern was the everyday Ugandan. Will they be able to pay this contribution?
Exactly.
And will it also be a burden on them? They're already suffering with so many other things. And the answer to that is that they're already paying for so many things out of their pocket. The contribution would actually help them, because it would mean that they have a saving. We don't have a saving mentality in this country. You'll see how NSSF was grappling with the concerns of people getting midterm access, saying, but, we're all going to go and buy cars and have a party. We're not. It requires us to understand that we actually need to instill a saving culture. And this is a start point. We used to have graduated tax. People used to pay. These very same people in the rural areas or the low-income communities spend money on other social activities that could be that money could be otherwise be mandatorily collected towards their health to supplement, and you'll find they'll take care of their health better when they're paying for it. Out of even 1,000 shillings, if you ask somebody, plant some yams, sell them for 1,000 shillings, and put it towards your health. Plant some sugarcane, sell it, put it towards your health. And there are different ways that can be done. Like I said, they all have groups in these communities. We can use those groups to get them to contribute. So His Excellency's concern was very valid. But we feel that there are already mechanisms in place that will get those people to contribute without them feeling that it's pushing them deeper into poverty.
I want to know how that can be done also, because I think it's very important. Now, we know of corporate organizations in this country that pay for insurance. They give medical insurance to some of their staff. And these are some people actually who can even afford, if they wanted to, just do the out-of-pocket bit of it, that they could still afford. And we now talk about an everyday person, and these are actually most vulnerable because of where they stay, how they feed, how they eat, how they live, and how they manage their health in a way. That's why our epidemiology department is actually bigger, because that's where we fall. Our problems are epidemic. And so I'm also thinking now, what needs to be done, and how are they supposed to do it? I'm only thinking, my mother is watching TV now, and she's thinking, okay, my son will possibly pay for me. But what about if my son is not able to pay for me? How am I supposed to pay? What am I supposed to pay? What does the law say if the president assented to it and becomes law in this country? What does that mean? How do we pay? When do we pay? Stuff like that.
Right. So that takes us back to what we were discussing earlier around the total health expenditure in this country. And the responsibility of government to provide health for every resident in this country. And at the end of the day, the buck stops with government. As a citizen of Uganda, I'm entitled to the government providing health care for me.
It's constitutional.
And so at the end of the day, that is where the buck stops. And now what we're saying is, let's join hands with government. Government is not going to stop budgeting for health. They're going to keep putting up infrastructure, they're going to keep buying equipment, they're going to keep employing health workers, because the network of providers to be used in national health insurance is both public and private. That is going to continue. However, what we're saying is, if we want to have a health system that we want to see as Ugandans, Ugandans also need to contribute to a scheme that is dedicated to providing them with health care. Now, your mother may say, you know, my neighbor doesn't have a son. Who can contribute for her? That is a vulnerable member of this community, and government has the responsibility to find a solution for that individual. If we look at the examples in the neighboring countries, there's special community-based health insurance schemes that are more affordable than the mainstream insurance. These schemes actually already in Uganda, they're covering over 500,000 people in this country. And these people are paying 20,000 shillings a year for insurance. And these schemes are functional, they're sustainable, and they're working. I was in Nsanji last week visiting one, and they collect 17,000 shillings from a member, and they're able to come. They're able to access
17,000 every
17,000 a year.
A year.
And
17,000.
no, a quarter, excuse me, a quarter.
3 months.
Yes, in 3 months. And that entitles them to health care.
That's about 6,000 shillings.
Exactly.
For a
and
month.
if you look at somebody who buys a newspaper for 2,000 shillings per day, how much is that in a month or in a year? If we look at those of you who like to enjoy some delicacies of pork and so forth on the weekends, how much is that in a year? So we're trying to say that everybody can find a way if they put their mind to it. If government makes it mandatory for you to find a way, it is like water. You will find a way to find that 1,000, 5,000, 10,000. In Kenya, I think the minimum contribution is 150 Kenya shillings per year, and then, per month. And then the maximum is 1,700 Kenya shillings per month for the high-end
About 3 million
contributors.
shillings Uganda.
Exactly. So we're looking at saying that we appreciate that there are people that won't have somebody to contribute for them, but government can step in to contribute for them because that is their constitutional role. However, we're saying citizens can also step in if we want to fast-track ourselves to the health system that we want to see.
Okay, then what about the limits now? So somebody will tell you, of course, for the health insurance schemes, they'll tell you, when you pay so much, you can only be given up to so much. There are limits to that. You can't say, I also want to be flown to Seattle, like Jacob Lokolio,
Right.
Because my wife is going to give birth, so I need her to go to the Bahamas or Germany or whatever.
Right. I think one of the things that we need to also bear in mind is that the health system is what it is. It's what we've made it, and as a country, what we've invested is what we're seeing, and so we need to make sure that we compel government and we pressure Parliament to make sure that 15% of the national budget goes to health. Then you will not need to fly to Seattle. In fact, we were having a discussion about how Uganda is supposed to be a health hub. People are supposed to come here because we have some of the most talented health workers.
That's true.
And some of our facilities are actually high-end facilities. So there's really no need for people to be flying out. If you go to the Cancer Institute, this is a government...
One of the best.
It's the best in the region. So there's really no need for people to be flying out of the country. However, we need to give people that level of comfort. We need to give people that level of confidence. And the way we need to do that is to give them the fact that they have access and it's affordable and they can be confident that they're going to receive quality care. The only way for us to do that is to invest in a national health insurance system, because then the money stays within. We will never become rich as a country if we keep sending money out to pay for another facility outside of this country to treat our citizens.
Okay. Yeah. President Museveni calls it medical tourism.
Yes.
Is that so? Medical tourism.
That's right.
Well, we'll take a break and return shortly and continue with the conversation talking about the National Health Insurance Scheme. We'll take a break and return.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.
Raising voices.
As a mother, my children depend on me to make this world a safer place for them. I'm not afraid to act when I see violence in the home and in my community. I promise to talk to my neighbors and friends about how we can nurture and protect the children.
In this time of COVID, what is your promise to the children of Uganda? Because a violence-free childhood is everyone's right. Raising voices.
It's time to teach. Schools are open. In these days of COVID-19, teachers are not only giving knowledge, but protecting themselves and their students from the virus. As a teacher, you must ensure that students follow the set SOPs of always maintaining a distance of 2 meters from others in classrooms, dormitories, entertainment halls, school vans and playgrounds, wearing a washed and clean mask every day that covers their mouths and noses, and regularly washing their hands with soap and water. In addition to that, you must counsel students about stigma related to COVID-19 and discourage them from violence. Any violence against students from classmates, teachers or parents should be reported immediately to a school administrator or senior woman or man teacher for correction and further guidance. Ensuring everyone's safety is key, so make sure students are out of class by the official closing time. Let's share knowledge, not COVID-19. This message is supported by the Ministry of Health, Ministry of Education and Sports, and UNICEF. Stay safe.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.
Well, thank you so much, and welcome back from the break. We continue the conversation, and with me in studios is Grace Chiwanukasali, the Executive Director of the Uganda Healthcare Federation, and of course discussing and talking about the National Health Insurance Scheme, a thing that had eluded Ugandans for quite a long time, and of course it is where we are today. Back at you, Grace, do you think this can be achieved? We can have it and enjoy it and love it?
Absolutely. I think we've come so far. It's been over 20 years. Our neighbors are looking at us. They took actually our template and have been applying it in their countries for over 10 years, so we know it works. The idea is good. One of the things we have to remember, it will not be perfect from day one. It will have to be refined along the way. Every country is doing it. Even countries in Europe, the UK, America, they're all refining their national insurance scheme, health insurance schemes, because it cannot be perfect. It has to adapt to the health system, it has to adapt to the population, it has to adapt to all manner of things in the country. But it is achievable, and it is really up to us to make sure that we keep applying pressure and keep asking the right questions so that we move and we get it implemented.
A whole chapter in the third National Development Plan, I think it should be chapter 17 or 18, talks about mindset change. Right. When you look at the parish development model, hinged on, I think, 7 pillars, and one of the pillars there is mindset. Now, a Ugandan will tell you, Nzasirwara, or I know how to manage myself. Just get katunkuma, just get this, just get that, and manage myself. You know, we have that mentality and the mindset. How do you think Ugandans will appreciate and understand these things? Because when you talk about insurance, for example, the concept of insurance is something very alien to Ugandans. When you talk about insurance, Ugandans can afford to insure an iPhone because it's a gadget. They feel they should be with it. And the Ugandan will not insure a house. They will not insure cars, they will not insure property, they will not insure businesses, they will not insure all the things. Because in any case, why should I insure my container? I am bringing goods in here, I am going to sell them and go. It's a car, I'm driving it the other day, sell it to another person, go buy another car. Why? They can insure a phone because they want to hold it for maybe 1, 2, 3 years. And they don't insure cars because they're sure, I will sell the car to Grace, sell it to another, and go on. The concept of insurance is what with us, the mindset of Ugandans. Shall we achieve it?
I think so. I think we just need to send the message, if you like it and you enjoy using it, then insure it. Because at the end of the day, they like the phone. You use it to communicate, use it for entertainment, you use it to move around. So you will insure it because you're thinking, I can't live without it. But you can't live without your health either. So insure that. I think the concept of insurance is going to take a long time because as a country, we're a very tangible country. We want to touch what we've paid for. You can't touch insurance until you actually need it. Insurance is, and actually the example you've given is a very good one, because if I have a sore throat, I can drink lemon tea, I can suck ginger. There are different things I can do in my home. I shouldn't really run to a clinic for a sore throat. Insurance is there for things that you cannot manage on your own. And that's why you'll find most health insurers will encourage you to come for an annual checkup to identify issues early. They'll encourage you to eat well. They'll encourage you to exercise. Those are all preventative measures that even the National Health Insurance is going to encourage people to do the same things, because we don't want you to claim, because we want to use that money for when you need an operation that you don't have the cash at hand. We want to save that money for an intervention that is beyond your financial capacity at that time when you need it. I remember when I used to work in insurance, we had a gentleman that came with sunburn because he had an insurance card. A grown man showed up, I have sunburn on my forehead. And we all know, just get some Vaseline and put it on. But now we billed his insurance for the consultant, the doctor, to look and say, yes, that is sunburn. Then for a prescription for Vaseline, yes, this is 4,000 shillings for you to get Vaseline to put on your forehead. That is 30,000 shillings that has billed his insurance company. But now, surely, it would have been much easier. He has Vaseline already on his dressing table. He would have just done that every morning and good to go. And that is how insurance is. We're trying to make sure people don't abuse insurance. And that is good. Like you said, it's going to be a mindset issue. It's going to be an education issue. But remember, we have over 1 million people in this country that are currently insured by community insurance schemes or by private health insurance. Those ones understand and appreciate the benefit. No company in this country would pay for private insurance for its employees if it wasn't seeing the value. Because then you're sure your employee will come to work, you're sure they're going to a qualified health professional, and you're sure when they go there they'll find the medication that they need or the diagnostic tools that they need. And that is the assurance we want to give every citizen of this country. You go to this facility, you can be assured of care. But that mindset, like you said, of I have to be able to touch what I've paid for, it is going to take a while for us to get there, but we need to start. We need to start.
And my concern is actually with a lady who gets pregnant and she knows she's 1 or 2 months pregnant this month. And she knows in the next 6-7 months I'll be giving birth, and they do not prepare themselves. No glove, no nothing. And they're actually just told when they're due that this is what you need, and you know, get to hospitals and say Tituna Chakola. Now there's a husband somewhere, a man responsible for the pregnancy and other things, and they have a plan for that to actually say, my wife is pregnant, and in the next 9 months, 8 months, or 7 months, or 6 months, or even 2 months from now, she'll be giving birth, and they do not prep themselves for that. Now, that's the people that we're talking about, that's the community that we're talking about, and that's the citizenry that we're talking about. And do you think they will actually appreciate these things? We need to make sure that they understand what you're talking about.
As I mentioned, as you mentioned, it's a mindset issue, but as I said, it's going to take time. Remember, a lot of these people have grown up with the mentality of it's free service. I go to Mulago, I go to Chirudu, I go to Sugu, I walk in and they will handle everything. Now, the challenge is that most of these people are not going for their ANC visits. They're not making sure that they're checking that their pregnancy is safe for them or their child. Even the father of the child is not checking that the person carrying my child hasn't got hypertension, hasn't got diabetes, that the baby is turned at the right time. All of those things, they're just waiting for God to do everything. Unfortunately, also God expects you to do something. And he expects you to do something for yourself, to prepare for yourself for that moment. And that is why we're encouraging people to really understand that it is about saving for yourself. No one is going to benefit from your money more than you. Everybody is going to benefit equally from the National Health Insurance Scheme. But it is important that we support each other, because like I said, you will support your mother but your neighbor, your friend, your workmate will call and say, I have a hospital bill. Can we do a car wash? Then you have to go and get your car washed, even if you don't need it washed. You will wash because you want to contribute. Now imagine if everybody was putting into a national health insurance scheme. You actually circumvent some of these expenses along the way to try and help your neighbor when they can actually help themselves.
We have these, like you said, at community levels, group levels, corporate organizations. And so what happens if the president assents to this bill to make it an act of parliament today or tomorrow, the other day? What happens when we see the president assenting his signature to the bill that was passed by parliament? So what?
Right. From there, we really need to come up with some regulations, because at the end of the day, there's some things that you don't put in the law that will help govern the operations of this national health insurance scheme. And you'll find that some of the delays and the concerns of a lot of stakeholders, and I know His Excellency had been engaging a number of the stakeholders and they'd raised concerns about the cost of doing business. All of those issues have actually now been addressed. And that's why the Ministry of Health is going step by step to engage these stakeholders, to reassure them that their concerns have now been addressed. However, there are some lingering operational issues that we're requesting that the legal minds that drafted this bill will then make sure that are sitting squarely in the regulations, because then that discussion starts. So he won't assent today, and we start on Tuesday next week. We will then have to draft the regulations that will come to help us operationalize that bill. And then we'll have to do again that we should really have started the sensitization. Because if in principle as a country we've agreed to have a national health insurance, it doesn't mean we can't sensitize people now to say, this is how insurance works. This is how you should prepare yourself for when insurance starts. Maybe you can even start saving now so that when it comes and you start contributing, you know where you're contributing from, how much you're putting in, and you have that cushion so you don't feel the pressure at that moment. So there are different things that we can do, and it would really be beneficial for us as a country, to the listeners that are the decision makers that are listening to this program, to think today, what can I do to prepare this country in my capacity where I sit, to prepare this country for this inevitable eventuality that is going to help all Ugandans.
Okay. And one of those final ones, how much has this scheme learned from the previous schemes, like the pension scheme, the NSSF, etc., etc.? Because I will tell you, my mother served in public service, and she
never got her pension.
At the age of 60. She's now maybe 80. She has never received her pension. I served in NSSF, and I've never received now. It also becomes a problem when you are part of the scheme now, when you are able, and the time comes when you need the scheme now to come to rescue, and it doesn't, or it takes forever because of systems still. Somebody will think and say, okay, we have learned from the pension scheme. What about if we went into this health scheme, and the other day I need so much money for this very complicated problem, and I need to go through these systems again that will never come?
Yes.
Until maybe I lose my person. What happens?
I think the most challenging part of this system will be enrolling people. After you've started contributions, you can actually, the good thing about health, you can access, you will get your card. You will have a card that entitles you to access care. So when you need it, you can go and test, does this actually work? To an accredited provider. That is the first thing. Secondly, then the relationship is with the fund holder. Ministry of Health, government is not going to be the fund holder. The fund holder is going to be a separate third corporate body entity. So it will not be the Ministry of Health that is managing the scheme. Secondly, thirdly, the composition of the board that is going to govern the scheme is going to be made up of a number of different individuals that are a mix. And this is listed within the Act of who will comprise of the governing board. So there's going to be that wide range of people that are looking at the accountability and the transparency of how the scheme is operated, and we're going to hold them accountable. We're going to be reviewing, we're going to have stakeholder engagements, we're going to have regional tribunals that are going to be looking at how is the scheme operating in your area. So it's not a hands-off, I'm going to wait till I'm 65 to find out if my money is still there. Throughout the lifetime of this scheme, the minute it starts, the tribunals are going to be put in place, the governing body is going to be in place, and all these people can be questioned and held accountable. And they're accountable to us because it is our money that is there. Okay. Yeah.
Okay, well, finally, health is also a very lucrative business in this country, and they'll tell you that. We recently had these problems, especially last year, mid-last year, when we had the Delta variant here, and people are being treated for COVID, and they had actually never thought about these things. We had talked about cancers and all these other diseases, but when it came to COVID, where somebody could go to hospital and after 1 month, a few weeks, a few days, and they tell them your budget is so many or so much millions, it just got people worried and thinking, now, we're next. And of course, everybody now resorted and said, okay, now these are private providers, very expensive, and yet are people even dying. They thought about going back to government. We talk about the scheme, and it's with somebody else, not the Minister of Health, not Mlago, not the National Referral Hospitals, and something like that. Will the people appreciate and understand that now, given the history of the private sector players during the COVID period?
It's actually a very good point you've raised, because the good thing about the scheme, and one of the things that we have to also remember about the COVID-19 Delta variant experience, is that when Ministry of Health examined the cost of providing care, they found that the private sector was actually not making a lot of money. The bills were big because the cost of critical care is high. It's high globally, but because no one has ever calculated the cost of care in government facilities, because remember, the costs are disaggregated. Somebody pays for water, somebody pays the salary, no one pays for it. So their money is never consolidated to work out the mathematics of how much does it actually cost to treat a malaria patient in Chirudu. No one has ever done that math. But when
because the costs are disaggregated.
Yes, because all the costs are disaggregated. But when the private sector was being crucified for profiteering from the pandemic, and then we said, well, you do the math and tell us, where can we get the savings from? They said, actually, it's costing us, government, also about 3.2 million per day to treat these people. So you're not actually profiting from the pandemic. And that is how that conversation actually went very silent. And if you look in the records of Parliament, I believe the Honourable Minister of Health herself actually sent those numbers to Parliament to say, actually it's also costing government 3.2 per day to treat a COVID patient. So when we look at how we're looking at implementing the National Health Insurance Scheme, and it's one of the issues I raised in the recent discussion, is we really need to study the cost of care and the cost drivers in care. We need to catalyze local manufacture of all these inputs that drive up the cost of care. Because remember, with COVID, we were importing most of these, and we had forex pressure. We had everything hiked, from even the freight costs went up. So all of that had to be built into the cost of delivering the service. So if we're to have a sustainable national health insurance scheme, that's why I said it's a multi-sectoral approach, because the other sectors need to come in. The manufacturers need to be catalyzed to produce syringes, cotton wool, drugs locally, so that we're paying in local currency, and that we're keeping the money within the country to keep growing as a country.
Finally, in 1 minute, your final take.
My final take is that, like, I just really appreciate that the stakeholders coming on board with having a national health insurance scheme.
Sure.
As the private sector, we're very much in support of having a national health insurance scheme. The concerns that we had have been addressed with the new revised version, whereby it would be the employee that contributes, not the employer. We've come up with a mechanism whereby indigents and the vulnerable would be catered for. Government would really look at how they would go about that. But for me, my ask is to the decision makers, the parliamentarians, the politicians. While we cry for our constituencies that vote for us, we need to look at the budget allocation to health to come up to the 15%, and we need to actually start the national health insurance. The way it is, let us start, and we refine it as we move along.
Thank you very much, Grace Ichwanukasali, the Executive Director of the Uganda Healthcare Federation. Thank you so much for having allowed to join us here on Good Morning Uganda today. And of course, it bounces back to all of us too. Now, think through it. Ask your leaders, because we trust our leaders more, especially the political leaders. Ask them about this scheme and tell them, how do I benefit? Where do I come in? What is it for me? And let me know, hope it's not just for members of parliament and ministers and MPs and all the others. How do I come in? I think it's a conversation that all of us need to get into and see how we even retune our mindset to appreciate the concept of health insurance in this country. We'll stop here for today. My name is Jagenda Semakola Ziksoka. Wishing all the best. Blessings. Goodbye.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.
It's time to teach. Schools are open. In these days of COVID-19, teachers are not only giving knowledge, but protecting themselves and their students from the virus. As a teacher, you must ensure that students follow the set SOPs of always maintaining a distance of 2 meters from others in classrooms, dormitories, entertainment halls, school vans and playgrounds, wearing a washed and clean mask every day that covers their mouths and noses, and regularly washing their hands with soap and water. In addition to that, you must counsel students about stigma related to COVID-19 and discourage them from violence. Any violence against students from classmates, teachers or parents should be reported immediately to a school administrator or senior woman or man teacher for correction and further guidance. Ensuring everyone's safety is key, so make sure students are out of class by the official closing time. Let's share knowledge, not COVID-19. This message is supported by the Ministry of Health, Ministry of Education and Sports, and UNICEF. Stay safe.
I was humbled before. This really humbles you. You appreciate life.
Tensions mount in Donbass with a massive explosion going off near a TV station in Donetsk as Ukrainian forces step up their shelling of the newly recognized republic. A fresh wave of sanctions targeting Moscow are triggered by the West, but Russia warns it's the global energy market on which the most pain will be inflicted. That as it defends its decision to protect the Russian-speaking population of Donbass. 90,000 have fled the violence there in recent days by crossing the border into neighbouring Russia.